Bismillah ar-Rahman ar-Rahim. Welcome back, everyone. Today we are going to continue our series of ICU Radiology, and this is part 3. So today we are talking about the opacified hemithorax or total lung whiteout. So 4 major differentials for that: pleural effusion that's occupying the whole hemithorax, atelectasis of either the right or the left main bronchus, pneumonia that's occupying the whole lung, or post-pneumonectomy, but this needs to be post-pneumonectomy that is chronic post-pneumonectomy, not an acute one, not immediately post-operative. So this is 31-year-old male patient, presents to ED with an acute shortness of breath. So you have considered the 4 differentials, but one of the most important factors that you need to see, that you have the trachea pulled towards the site of the total lung whiteout, and that gives you an impression that this is an atelectasis. Another thing that you can do in the ED, that you can do a lung ultrasound, and that can differentiate easily between atelectasis and massive pleural effusion. But differentiation between atelectasis and pneumonia is difficult with the lung ultrasound, and in spite of having this typical appearance of static air bronchogram with atelectasis and dynamic air bronchogram with pneumonia, but this is not enough by itself to differentiate between atelectasis and pneumonia. So in pneumonia, the airway or the trachea will be central, unless there is another factor that is pushing or pulling the trachea to one side. But in atelectasis, the airway tends to be pulled towards the site of atelectasis. This is the X-ray of a child, 3 years old, presented with wheezes and shortness of breath to ED. And again, you can see that the airway is shifted towards the total lung whiteout, so the massive total lung whiteout on the left side, and the signs towards the cause of this total lung opacification, that you have the airway shifted already towards the site of the atelectasis, and also you have the heart itself shifted as well. So we cannot see the right border of the heart to the right side of the spinous processes anymore. So this is the spinous process, and the right border of the heart is actually overlapping the spine, which indicates that the heart is shifted to the right side, to the site of the acute total lung whiteout, and that indicates atelectasis. Another case of 58 years old man, presented with a shortness of breath and fever, with a complete opacification of the right side of the lung, so total lung whiteout in here. So in this example, you will notice that the trachea is shifted away from the effusion. So trachea is shifted to the other side. And also the heart is displaced towards the lateral chest wall, to the other side of the effusion. And these findings are characteristics of large pleural effusion. Again, if you do a lung ultrasound, that is a very easy differentiation between the pleural effusion and the atelectasis or pneumonia. But I'm talking now about the chest X-ray, because if it comes in the exam, you will have to know these signs. But on practical basis, you can do a lung ultrasound and easily differentiate between them. Another example of a 68-year-old man who presented to ED with shortness of breath and of heavy smoking. So what we can see here is a combination of large effusion, which is the E, and atelectasis of the lung, which is this black arrow. And essentially you'll find that the cardiac structures are still in the normal position because of the combination of effusion, which pushes to the other side, and atelectasis, which pulls to the same side. Or you might argue that the cardiomediastinal structures are more pushed rather than pulled because of the huge size of the effusion. But there is a combination of 2 opposing pressures, which is the pushing pressure by the pleural effusion and the pulling pressure by the atelectasis. And the presence of a combination of atelectasis and massive effusion in a patient, especially if smoker, is an ominous sign, severe sign, raises a concern about bronchogenic carcinoma in a smoking history patient. All right, what do you think about this X-ray for a 48-year-old patient who presents with fever and acute shortness of breath to the ED? So you can see here that there is diffuse lung opacification of the total lung on the left side, so total lung whiteout of the hemithorax on the left, and the cardiac border is not shifted, so the heart position is the same, but there is slight shift of the mediastinum of the trachea to the left side. And this consolidation with air bronchogram that is occupying the whole lung gives you an impression about the possibility of pneumonia, because there is no severe shift here. It can have some shift, but not as severe as atelectasis. And there is air bronchogram, there is no cardiomediastinal shift to the same side of the total lung whiteout. So that gives an impression about pneumonia, especially if you combine the data that we have from the history. So this is an X-ray for a patient less than 24 hours after pneumonectomy. So you can see the surgical clips in here indicating pneumonectomy, and you can see here jet black. So that's a very important differential if you have an X-ray in the exam that the stem says that the patient is post-operative or the patient is a heavy smoker, and then you see the surgical clips and then you see this, which is a jet black appearance on the total right side of the lung. So you think, oh, is that pneumothorax? But history, surgical clips, jet black appearance gives you an impression about fresh pneumonectomy in the first 24 hours. Sometimes you can see that surgical removal of the rib as well, especially the fifth rib, but might not be apparent here. Or you can see it here, it's a clearer version of the image. So that gives you another indication or another impression that this is a pneumonectomy. But how about this chest X-ray? After 1 year of pneumonectomy, you can see that the mediastinum, the trachea is shifted to the same side. There is a total lung whiteout or opacification on the right side. And the heart itself as well is shifted to the same side. And you can see all of these surgical clips. So that gives you a strong impression that this patient had a pneumonectomy. So tracheal shift, mediastinal shift, cardiac shift, surgical clips, history as well, and 1 year later, then this is a total lung whiteout on the right side because of pneumonectomy. So this is the chest X-ray of a 53-year-old male asthmatic presented with a shortness of breath. What do you think? So there's like a triangular suspicious opacity in here with a minor shift of the lung fissure, which is called the minor fissure, shifted or pulled upwards because of the atelectasis. So this is atelectasis. And this is associated with a slight shift of the trachea to the same side of atelectasis, to the right side. Again, what do you think about this chest X-ray? So total lung whiteout on the left side here. And you can see the course of the nasogastric tube. So the nasogastric tube, the trachea, both are pulled at the same side of the total lung whiteout. That indicates that this is atelectasis. Also, the heart is pulled out because you cannot see the right border of the heart to the right side of the spinal processes. So that has been pulled. So again, what do we think about this chest X-ray? So there is total lung whiteout on the right side with a mediastinal shift to the same side of the total lung whiteout. And the heart and the mediastinum have been shifted as well to the same side of the lung whiteout, and that indicates atelectasis. This is another example of atelectasis, which is band atelectasis present in patients post-operatively. And this is an example of compression atelectasis, so effusion surrounding an atelectatic lung in here. So that is called compressive atelectasis. So this is what is called S sign of Golden, which is a combination of a hilar mass, this one, with this border, hilar mass in here, and atelectasis in the right upper lobe. And the shape of the curved edge caused by the mass gives the name of the S sign of Golden. And usually this indicates the presence of bronchogenic carcinoma. Okay, next one. So 58-year-old male who has been just intubated and is difficult to ventilate. What do you think about this chest X-ray? So there is right upper lobe and left lung atelectasis. So you can see the tip of the endotracheal tube, which is down the right main bronchus, and that caused right upper lobe of the lung to be collapsed, plus the left lung to be collapsed as well, so total lung collapse on the left side, and that's why this patient is difficult to ventilate. The minor fissure is also elevated here, as you can see, and the solution for that is to pull the endotracheal tube back to the normal position, 3 to 5 centimeter above the carina, and then you ventilate again, and the atelectasis will resolve after good ventilation. So this is a 73-year-old male, 3 weeks after a STEMI, presented with a shortness of breath, chest pain, and fever. What is your diagnosis? So there is left pleural effusion, and you can see the meniscus sign here. So this patient has had pericardial effusion as well. He had a cabbage. So this is what's called Dressler syndrome. So Dressler syndrome is left-sided pleural effusion, pericardial effusion, associated with chest pain and fever, and patchy left lower lobe consolidation. And usually Dressler syndrome responds to high-dose aspirin and or steroids. And we can see that this patient has a dual chamber pacemaker as well. Alright, so this is an example of normal costophrenic angle here. You can see the sharp edge of the diaphragm here that meets with the chest wall and produce the lateral costophrenic sulcus. While this is an example of blunted costophrenic angle, and that happens when the pleural effusion reaches around 300 mils. The costophrenic angle becomes blunted. So what do you think about this costophrenic angle in here? So there is scarring of the left costophrenic angle due to previous infection or surgery or hemithorax, and that is what is called ski slope appearance. Ski slope appearance of the costophrenic angle. And this is characteristic that this costophrenic angle has had infection or inflammatory process. So what do we think about this chest X-ray? So this is called the meniscus sign of pleural effusion. So you can see that the effusion ascends here laterally more than what it ascends medially, and that's called the meniscus sign. And then we talk about the effect of position of the patient on the appearance of the pleural effusion. So this is a pleural effusion on a patient that is supine. You can see that there is haziness or veeling over the entire hemithorax here, and there is no distinct margin of the effusion. While this is the same patient in a more upright position, notice that you have a clear border of the pleural effusion, and there is more clearance of the upper part of the lung, so less veeling than the previous one. Okay, what do you think about this one? So this is a large hemothorax on the right side of the chest, and you can see this is fluid, the large amount of effusion here. This is fluid, and you can see that the fluid is denser on the bottom than at the top, and this is called fluid level. Fluid level. That raises suspicion about separation of the blood products, and that will occur in cases of hemothorax. And on the lung ultrasound, this is called hematocrit sign. So you'll see the same if you do an ultrasound of the lung. You will see that there is pleural effusion, and you can see layering of the cells and clear pleural effusion above that. So that is called hematocrit sign. And you can see clearly that there is mediastinal shift here. The cardiac structures and mediastinal structures all are shifted to the left side, and there is complete atelectasis of the right lung. You can see this is a large left-sided pleural effusion with a total lung whiteout, and there is a mediastinal shift to the right side here, and you can see the trachea is shifted to the right side, and the heart as well. This is the right heart border shifted to the right side, and all of that is because of the large massive pleural effusion with the total lung white out on the left side. So what do you think about this chest X-ray? This is bilateral loculated pleural effusions. So on the right side you have this, loculated pleural effusion, and on the left side you have this. And usually they are created by adhesions. And if you see any effusion that looks that it doesn't have a meniscus sign and in an abnormal position of the lungs, then suspect loculated pleural effusion. Same like this one. It's like a pseudotumor sort of mass, and it's at the minor fissure in here. It's like a lemon. And usually these pseudotumors appear or occur at the fissures, and that helps to differentiate between the pseudotumors and the actual tumors of the lung. So what do you think about this chest x-ray in a 38 years old male after a stabbing injury? So this is a hydropneumothorax. It's a combination of pneumothorax, you can see the lung border here, and hydrothorax with an air fluid level identified by these arrows. So unlike the pleural effusion, the hydropneumothorax will produce an air fluid level with a straight and sharp edge, and that air fluid level is actually characteristic of hydropneumothorax. So this effusion doesn't follow the meniscus sign and go up. That will form an air fluid level. So another x-ray of a 44-year-old male presented to ED with a shortness of breath and fever. So you can see that there is an airspace disease here on the left side of the lung with a consolidation, so confluent, hazy, cotton-like opacity with air bronchogram and indistinct borders. And that's in contact with the left border of the heart, so it obscures the left border of the heart here. So the left border is cannot be distinguished on the left side. So that is again called silhouette sign. Because the pneumonia and the heart are the same radiographic density, the border between them disappear. So what do you think about this one? This is right upper lobe pneumonia, and this is what's called lobar pneumonia. So occupies the whole lobe of the lung, of the right lung, the upper lobe, and you can see the margin of the lung, the horizontal fissure forms the margin. Let's draw it again. Yep, of this pneumonia, with the inferior margin of the pneumonia sharply marginated and demarcated, and that was a pneumococcal pneumonia at the end. So this is another example of pneumonia, and this is bronchopneumonia, and this is caused by Staphylococcus aureus, so Staph aureus. And you can see multiple irregular marginated patches of airspace disease in both lungs, like here, 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 and here. This is another type of pneumonia, which is cavitating pneumonia. So you can see multiple cavities in here, here, here. And the most common causes are TB, fungal infection, staph, Klebsiella, and Pseudomonas. And this is an axial CT talking about bibasal changes of the lung. And this is most likely aspiration, given that this is at the most dependent parts of the lungs. So this is all for today. We talked about the pleural effusion, atelectasis, and pneumonia. Hope this was useful. See you next time. Thank you.